Hi, my name is Tyler Scott. I'll be presenting a case report on diaphyseal femur fracture management in an elderly patient with achondroplasia. Achondroplasia is the most common cause of short limb dwarfism and the most prevalent form of skeletal dysplasia. More than 95% of these individuals have a single point mutation in the fibroblast growth factor receptor 3 gene. This gene regulates linear bone growth. The mutation inhibits endochondral ossification and impairs cartilage matrix production. These features that are associated with achondroplasia include short stature, rhizometric shortening of the proximal limbs, genu varum, limited elbow extension and rotation, hypersensibility of joints, and exaggerated lumbar lordosis. These patients also have cardiorespiratory and neurologic comorbidities. There's approximately a prevalence of 1 in 20,000 live births. There's a lack of literature describing the treatment of long bone fractures in adult patients with achondroplasia. We aim to describe the surgical management of an elderly patient with achondroplasia who had a traumatic femur fracture. Our patient is an 83-year-old male with achondroplastic dwarfism who presented to the emergency department following a mechanical fall from his bed. He was unable to weight bear at the incident. Radiographs of the left femur demonstrated a mid-shaft spiral fracture of the left femur in figures 1, 2, and 3. The surgery technique. So the operation was performed under general endotracheal anesthesia. The patient was positioned supine on a radiolucent table. A bump was used and traction was applied to the femur. A radiolucent triangle was then used to put the left lower extremity over the triangle. 2 centimeter midline incision was made anterior to the patellar tendon, which was split in line with its fibers, dissected down to the nuts of the femur. A 2 millimeter terminally threaded guide wire was in place under fluoroscopic guidance, and its position was confirmed in the AP and lateral planes. A 14 millimeter intrareamer was then inserted over the guide wire. The guide wire was removed. A long tip ball wire was placed to the level of the fracture site. At this time, the fracture continued to be malreduced and in a non-anatomic position. The decision was made to make another incision on the lateral aspect of the femur to get an adequate reduction. The Loman clamp was placed to anatomically align the femur and hold the femur in appropriate reduction. Once the reduction was achieved, the long ball-tip guide wire was passed proximally into the intertrochanteric region of the patient's proximal femur. Fluoroscopy verified that the femur was well reduced. The ball-tip guide wire was then measured and found to be approximately 245 millimeters in length. The canal was sequentially reamed up to 12.5 millimeter reamer, and an 11 by 240 synthese retrograde femoral nail was placed over the long-tip ball guide wire and mounted in position. The nail was fixed proximally and distally with non-locking screws. Fracture remained reduced once the clamp was removed. AP and lateral floor images were taken of the entire femur to demonstrate the appropriate reduction. Figures 6, 7, and 8 demonstrate the reduction. Patient had an uneventful recovery and went straight to the floor after PACU, and he was made weight bearing as tolerated. Discharged day 4 back to his facility. 5-week post-op visit. He was doing well overall. Pain was controlled. He was not taking narcotics. He was at a rehab facility and been working with physical therapy. He was able to weight bear and work on strengthening and gait training. Radiographs of the left femur revealed a stable retrograde intramedullary nail of the femur fracture with interval callus formation. To date, there's little to no literature describing fixation methods for long bone fractures in elderly patients with achondroplastic dwarfism. Perioperative management is challenging given the classic skeletal features of these patients. This case presented a mid-shaft spiral fracture of the femoral shaft, and this elderly achondroplastic male insinuates the complexity of fracture fixation in these patients. We conclude in our case study that retrograde nailing of the distal third femoral shaft fractures in adult patients with achondroplasia is an appropriate and safe technique that allows stable fracture fixation, early weight bearing, and potential for decreased blood loss. And an operative time, which is imperative in this population, is decreased. Careful preoperative planning, medicine consult clearance should be undertaken for these patients. Femoral bow and anterior bow of the femur are selected. Nail demonstrated a large mismatch given the potential dysmorphic appearance of the femur. In these cases, alternative fixation methods such as a locking plate should be considered. Thanks.